So, the last talk, 10 minutes, and it's finished. But it's important to look at, because the MPFL is probably the biggest surgery which is done for patellofemoral instability. And if you go to the literature, and there is one fantastic article, the one from Christian Latterman, he showed 26% of complication, failures, of problems. So it means that it's not nothing. And I like to say that MPFL is a technique. It is not exactly the technique and the solution for patellar instability. Of course, it is easy to do. You have a small scare comparing to the old-fashioned TT osteotomy. And it is sexy, attractive, like Mrs. R. Elera Gomez, this guy in the middle, is the one who described the first MPFL. He's a Brazilian person, surgeon, and he's a very, very nice person. He didn't know that he will discover this MPFL in 1992. But as everything which is sexy and attractive, it's dangerous, of course. So be careful about MPFL. No, it is recorded, so I cannot say anything. What could lead to patellar dislocation after an MPFL reconstruction? The technique, wrong positioning, over-tensioning, under-tensioning, graft failure, material failure. The indication, and this is one of the biggest cause of failure, done surgery for painful syndrome, didn't know the instability factor. So every time you have an MPFL failure, the cause is a surgery. Yes. So the technique, position, mostly wrong placement on the femoral side. You see, if you have such MPFL, how could it work? Impossible. Elvira Servia showed clearly that even in a trained team, they can have some differences, unbelievable in terms of MPFL positioning on the femoral side. So what to do is to use the fluoroscopy every time. And when you use the fluoroscopy, you have to know exactly that your both condyles are on the same line. Be very careful about that, because if not, you can use the fluoroscopy, you say it's a perfect, super, I use a fluoroscopy, but if the condyles are not on the same line, you end up with a terrific position. And it does happen even to very skilled surgeons. It's important to know the anatomy and the biomechanics, of course. So the technique, over-tensioning or under-tensioning, this is depending on the position of your MPFL. And for example, this patient, you see perfectly the MPFL, beautiful when you see that, fantastic MPFL. But in fact, it is because it's over-tension, too much tension, and the wrong position. So what to do with that? You cut it. You just cut it. And it works so well with patients, because those patients, they came to you and say, it's painful, and I cannot flex, they are stiff in flexion, because most of the time the positioning is too high. And they had the MPFL by the surgeon, they were stiff, unhappy, and the surgeon said, okay, I will do an arthroscopy on you just to do an arthrolysis. They go in the joint, they don't see any adherence. When the patient is sleeping, the flexion is full. So the surgeon said, okay, I did the arthroscopy, but the patient is the same. But it's because they are stiff in flexion, not because you have adherence, it's because it's painful. And on such patient, you cut the MPFL, 1 hour after surgery, your patient says, oh, fantastic, feel so well, and I have no more pain, and usually they do not re-dislocate. So this is something to know. You can have some breakage. It's what I was saying before. This is for me definitely the worst technique to use to do a drilling of your patella. It's very, very dangerous. Sometimes you miss the tunnel you have done, or you put the screw just behind the tunnel you have done, so it's a little bit strange. It doesn't work too much. And for example, this patient, it's very fun because he had this screw behind. You say, okay, so the surgeon missed the tunnel. But if you look to this patient, Blumensack line, groove line, no crossing sign. So this patient actually no patellar instability. It was a painful syndrome, and it's very, very awful, for sure. So when you have that and then you put two screws like that, of course your patient will not be so happy. So never do that for sure. So you have to understand that the MPFL works if the patella is facing the trochlea. It's not a realignment procedure, definitely not. So, if you position it too proximal, you will be tight inflection. It's what we were talking about just before. If you put it too distal, it will be loose inflection. So, the femoral placement is very, very important. Very important, and you can most of the time you have some abnormality on the femoral placement, not on the patellar placement. So
can I stop you just one moment for this argument? You can come back. I think this is the reason, because if you have to make a mistake, it's better more distal.
Yes.
Because the ligament works in the first 34 degrees of flexion, and then if he's losing flexion, this is called the femoral anisometry, you don't have problems. So if you have to make a mistake, it's better to have a mistake
distal. Yes. Oh yeah, definitely, for sure. And the anterior posterior placement also is also important. If you go too posterior, it's better to go a little bit too posterior than too much anterior, definitely. That's for sure. So if the patella is not facing the trochlea, your MPFL will not work in a good biomechanic condition. And if it doesn't work in a good biomechanic condition, you will have a biologic failure, as here yesterday. Okay, you will have pain, you will have a tunnel widening, and you can have some recurrence. So it's important to understand that the shape of your trochlea will create some different native MPFL for sure. And the MPFL on this patient here is much longer than this one, of course. So this is important. If you have a patella alta, look at this terrific patella alta and the engagement. So it is totally different from this patient, this one, or this one. So what does it mean? It means that the biomechanic of your MPFL on this patient at the beginning, the MPFL is here, okay? Okay, perfect. And if you correct the patella alta, the MPFL will be definitely different in terms of length. Okay, so if you do this MPFL, this one is definitely, is anisometric, but not favorable anisometry. So if you repair this MPFL, it will not work perfectly, for sure. And for this one, of course, the same. How could an MPFL relocate this patella? Impossible, unless that you force, you overstrain your MPFL, but the pressure will lead to a failure of your MPFL. So we are all fighting to find the right placement of your MPFL on the femoral side using fluoroscopy, is what I said to you, of course. But if you do not correct the bump or the patella alta, even if you put your MPFL exactly at the right placement, the patella is not at the right placement. So the mistake is done by the anatomy, and you will get a failure, of course, because the biomechanic of the MPFL is not good. So this is something so important to understand. So you have seen that at least twice, so I will go fast. But this is also a cause of a failed MPFL if you do an MPFL on the patella alta with no sagittal engagement. So this is a big cause. So in conclusion, when you indicate an MPFL, first of all, is that a true lateral instability or dislocation? Second, do this patient is eligible for an isolated MPFL? Subjective instability or objective? You have seen that before. So only for objective instability, you do the listing of the risk factors, the trochlear dysplasia, the patella alta, the value of the TTTG. So measure, 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 measure. Once again, take your ruler, take your computer and your softwares to measure all the things, and you will be able to know exactly if your patient is in. So no good MPFL is no trochlear dysplasia or no type IA, but no type B, C or D. No patella alta or patella engaged in the trochlea. No excessive TTTG. And if you have a tilt, you have to add a lateral release definitely. So in conclusion, the most common fault which lead to a failed MPFL is the no good imaging analysis. Somebody who knows nothing about X-rays and CT scan, etc. Who knows nothing about the risk factors. So in fact, a very, very ignorant surgeons. Don't be ignorant. But today now you are so skilled about the patellofemoral. Thank you so much.